introduce a very person well known to World Medical Mission in Samaritans Purse, and a very godly man and a good friend of mine, Dr. Paul Jarrett. Dr. Jarrett is, of course, specializes in OB/GYN, and he did his training at the University of Indiana years ago and practiced for many, many years domestically. I've met Paul many years ago at Prescription for Renewal, and I remember when he and his wife made a dedication to the mission field. He did that at age 54 in 2000, in the year of 2000, and he and his wife Marty and their 6 teenage daughters served in Tenwick Hospital for 6 months at a time for 7 years. And then, unfortunately, his wife Marty became very seriously ill with breast cancer. Marty has passed away 4 years ago and is now with the Lord, united with the Lord. But Paul continues to serve. He's been at Tenwick on 15 occasions with World Medical Mission, as well as other low-resource places around the world. He likewise plans to serve at Mabingo Hospital in Cameroon starting in late February. And today I'm delighted to introduce him, and he, of course, is going to discuss obstetrics in the tropics. And so with that, Paul, I'll turn it over to you.
Well, I think with the cold weather that we're experiencing in North America, maybe we ought to be talking about obstetrics in the Arctic. And I recently saw a cartoon. There is a woman in a parka there speaking to her husband. He says, "I think my water just broke," and there's a group of ice cubes between her feet. So I think there are challenges in all over the world now. But maybe the tropics look pretty good today. So I want to warn you some of the things that maybe you'll be encouraging there or be encountering there. So going to the first slide there, and remembering the reason that we're going out is to make disciples of all nations, baptizing them in the name of the Father and of the Son and the Holy Spirit, teaching them to observe all that I have commanded you. And we are going out often as the bait, so to speak, for others in local churches and our staff to evangelize, and we're able to do that ourselves as well when we have the communication availability. So it's been a blessing to be able to do this, and I just would encourage you to use the talents that the Lord has given you and join us. I'll kind of skip through the first few background things, as Lance already talked about. We want to present an overview of maternal mortality and then familiarize you what we call third world or low resource OB/GYN care might be encountering, like unusual diseases that we might not see here in the States, and managing some of these common problems. Maternal mortality is well defined in our textbook as being the death of a woman while pregnant or within 42 days of termination of the pregnancy, irrespective of the duration or site of the pregnancy. In other words, it might be ectopic as well as intrauterine. And then we express a rate or a number in the number of maternal deaths per 100,000 deliveries. There's over 500,000 worldwide. Who knows about the real numbers? This slide is actually probably 10 years old, but I think you look at the range of it in rural areas of Gambia where there's very little access to care. 1 in every 50 mothers might die with a pregnancy compared to maybe 1 in 25,000 in Western Europe. And just looking at what they say about urban India, 545 per 100,000, that was the rate in the United States before in 1935, a little under 80 years ago, when we didn't have blood banking or antibiotics. So obviously our situation has changed greatly here, but for rural areas without access to care, this has not changed a great deal. In my 30 years of practice in Indianapolis, I personally observed 2 maternal deaths, and both were not really particularly obstetrical. They were medical complications of a couple of the mothers. But in Kenya, I've had 2 maternal deaths in one night on 2 different occasions. And usually we have at least one a month at Townwick Hospital in our regular monthly maternal mortality committee meeting, or at least a discussion. And I think this is one of the most difficult challenges that a visiting doctor experiences in coming to a resource-poor hospital, just processing the emotions from losing a mother. And in contrast to the situation where the patient may be comatose when you first see her, she's really not become a person that you know. It's really difficult when you've interacted with her as a patient and you've touched her, examined her, you've perhaps prayed with her, and you watch her die despite your best efforts due to the lack of equipment or personnel, medications, blood, and sometimes even your own skills. So I think those are the challenge. That's a big challenge that someone will go through in going to a hospital. And I think that the only way to deal with that is to start the morning in your Bible study and prayer and turn it over to the Lord and lean on Him throughout the day, depending on, whatever you're going to incur, and know that you do everything possible that you can, but it is ultimately the Lord that is going to enable you to do anything. There's many contributing factors to the status of a woman in society. For example, so we use the word chattel or property. It's often the husband that makes decisions as to what is going to happen to the woman in the hospital. Is he going to bring her there? Is he going to allow us to operate or do whatever it is that we need to do to try to save her life and her pregnancy? Often the times there's been poor nutrition at various times. A lot of these areas are subsistence farming, and you're only as good as your last crop, and crop failure can lead to chronic malnutrition in areas. Women traditionally have not had the ability to go to school, so there's low literacy rates, and then just getting to the hospital or to good medical care is often a problem. At night, there's not transportation. We often see at the local government hospitals, the ambulance doesn't have petrol, we call it there, or gasoline, so the family has to come up with the gasoline to take the patient to the referring hospital. So that's just a huge issue. Gets better with time. We see more transportation available, but it's very hard to ride on the back of a motorcycle when you're pregnant in labor. Obviously, poverty is a huge issue, and the parasitic diseases we see may lead to severe anemia. And we're going to go through some of those conditions. And then just inadequate medical and obstetrical care. We're training interns. We have them for 3 months of their internship year, and from there they go to a local government hospital, and they're expected to do primary cesarean sections there. So we have a big job to do in that little time that we have with them, and giving them between 30 and 40 cesarean sections during that time where they're taught to do that. And so that's big when you're going to these low resource areas, is training other individuals, be them nurse midwives or interns or residents of some level or specialty. So those are big factors, obviously, in maternal mortality. In addition to mortality, there is morbidity, and that may be many times greater than that. The long-term disabilities that we see are vesicovaginal fistulas, rectovaginal fistulas, chronic fourth degrees, chronic cervical lacerations never repaired or recognized at delivery, sterility, chronic pelvic pain. All of those are significant morbidities as a result of childbearing misadventures. A very typical scenario that we see repeatedly is this young girl who undergoes a long delayed cesarean section by the time she finally gets to us. The baby's already dead or dies in the nursery shortly afterwards. She develops a week later perhaps a vesicovaginal fistula. She develops a wound infection. Often the uterus is destroyed. It requires a hysterectomy sometimes so that she is permanently sterile. And then she often smells very bad because of the incontinence that she has, making her a social outcast. And if she's unmarried, she has no possibility of marriage. If she is married, oftentimes the husband will take a second wife, making her a second-class citizen for sure. Perinatal deaths are even greater, and the numbers aren't too meaningful. 180 for every maternal mortality. That's an awful lot, but it is translated. We don't get babies to survive prematurely before age 31 or 31 weeks gestation. And even in our more advanced situation at 10-week, relative to what's available in the local communities, we have a large number of stillborn and asphyxiated babies, despite all of the efforts that we make. In the States, you're going to certainly be familiar with the most common reasons for maternal death: hypertensive disorders, the pregnancy postpartum, infection, and hemorrhage. Well, certainly we see a lot of that, but we've got another list that you won't see commonly here: tetanus, HIV/AIDS. Of course, you'll see that your patients often are on drugs for that. Malaria, which is one of the biggest reasons I think of as maternal mortality causes. Viral hepatitis, sometimes a little hard to distinguish from malaria. The symptoms are very similar oftentimes, and don't always have the lab to help you even differentiate what that would be that you're dealing with. Obstructed labor is very common, and anemia that we'll talk about. Abortion, both spontaneous but also induced abortions are common now in Kenya, and it's often that we have a mother recovering from such a procedure and a complication usually from it. Ectopic pregnancies, and they're a little different often, which we will talk about, and cardiac disease, and should perhaps have added pneumonia to that. All of those are reasons for maternal mortality that we have seen at 10-week, and usually more than once or twice. The hypertensive disorders, we'll kind of skip through this because most of you are quite familiar with PIH, chronic hypertension, chronic renal disease. Usually the PIH is associated with primogravidas or multiple pregnancy, twins or triplet pregnancies. Poor nutrition, sometimes the extremes of age, below 16, above 35, underlying high blood pressure, renal disease. And one we've seen once or twice at 10-week is remarriage to a second husband. You might see that more commonly in the States, whereas it's a little unusual in our situation for patients to remarry once she's widowed or been divorced, but it does happen. Of course, PIH is a multisystem disease with a triad of high blood pressure, edema, proteinuria. Eclampsia is where that is complicated by generalized seizures. HELP syndrome is a subset of that, but we see quite commonly at 10-week, where hemolysis, elevated liver enzymes, and low platelets. And then this complication list that you see from PIH: heart failure, coma, blindness, stroke, liver rupture, renal failure, death. We've seen all of those at 10-week hospital, generally because we get patients fairly late from the referring places or from home oftentimes where they've come in. If we are seeing a patient with severe PIH, management is bed rest in the hospital. There's hardly any place that you can do outpatient management for severe high blood pressure, whether in the States or there. You want to get the patient delivered as soon as possible. Sometimes we delay if we think we can get the baby close to our cutoff time for survival. And we want to prevent seizures. We use lead sulfate primarily, and we have generally used the 4-gram IV loading dose with 1 gram an hour, and following that then with reflexes to be sure the patient still is reflexic and not overdosed or not underdosed because she's still hyperreflexic. That is a challenge sometimes because we don't have anything other than just a little wheel on the IV line to regulate that dosage, and that can get away from you if you don't have nursing care that's really close watching the patients, or maybe a family member changes the dose or something like that, thinking it's not running very well. An alternate is to give the Parkview or hospital out of Dallas, or Parkland, the 5 gram in each hip for a total dose of 10 grams, and then 5 grams every 4 hours. I think that may be in some situations a safer alternative. So keep that in mind, that even though we might not be using that in the States, that might be better in some situations. And we generally try to treat the patients for 24 hours after delivery. We often see patients given Valium or Dilantin either on their way there or either in our casualty. It is used, but it's a little less effective than mag sulfate for seizure control. We don't want to drop the blood pressure very low on these patients, as that may reduce uterine blood flow to the point that the baby will be either in distress or killed by that drop in blood pressure. We use methyl-dopa, which is albumet, and hydralazine, and we sometimes are able to use labetalol or nifedipine as alternatives to that, although not with the mag sulfate. The nifedipine is not to be used with that at the same time. Mag sulfate is only seizure prevention. It is not an antihypertensive drug, and although sometimes our interns are thinking wrong on that, so you have to kind of watch what they're thinking as well. Check the patient when they come in seizing. A lot of them are in very advanced labor, maybe just have the baby on the perineum and it's ready for delivery. So don't get too far gone with your treatments before you begin to examine the patient. And of course, delivery is a very important step in reversing that process. You do see chronic hypertension very commonly in black-skinned individuals, and that's 99.9% of what we're dealing with in Africa, certainly. And they are at risk of worsening this disease with superimposed PIH. We use albumet prenatally, nitrohydralazine, and that is unless they're in the hospital for acute management. We don't want to use diuretics because they're often vasoconstricted if they have PIH, and that only worsens the situation. We see obviously more growth restriction in stillbirths. We do try to follow with ultrasound for growth when that is available. That isn't going to be available in all settings. And even at Tenwick, we need now a new OB ultrasound unit because the last one finally had died just last week. So we're going to be looking for that. But don't continue these pregnancies post-term. A lot of times there's kind of a passive attitude in nurses, in the MCH, maternal-child health prenatal clinics. We see some of these patients coming in 41, 42 weeks. Well, they should have been delivered before that time. So we want to be proactive in getting these babies delivered at term. Knowing the patient history is important, and often you don't know exactly when they're due. That's a big challenge, is knowing when a baby is actually due, when is it just small for growth, for development. Changing to infection as another major mortality. Sometimes the birth attendants are lay people without any real training, and we're doing some things that would produce more likely infection or prolongation of it before referral is done. You often see episiotomies that have been done, or just lacerations that have not been repaired and infected. You see retained products. Sometimes placenta is not delivered, or they've torn off part of it, or broken off the cord, something like that, and you don't really know quite what's left inside and why the patient's infected. We know that the cesarean section has a big effect on the risk of mortality and morbidity with puerperal infection. Long obstructed labor, obviously, and prolonged rupture of membranes, and sometimes very passive management of that. The patients have gone days without intervention at term with ruptured membranes. Meconium may be an independent factor, and obviously anemia and HIV makes everything worse. And so those are big co-factors. When we're seeing puerperal infection postpartum, you've often noted a foul-smelling baby. Foul-smelling lochia, sometimes about a day ahead of when the uterus is tender or when they have a fever, you notice the lochia is not the right odor, and be alert to that. Obviously, fever and tender uterus are good signs of that. Leukocytosis. And a lot of times postpartum hemorrhage, there is some degree of the puerperal infection involved with this. And what we use is a combination of triple antibiotics, Ampgent and Flagyl. Generally is used if renal function is in concern, and ceftriaxone and metronidazole is also a consideration for that situation. Obviously, you want to evacuate the uterus if there's membranes or placenta left inside. If there are abscesses that have delivered or developed, usually in the wound on a postpartum cesarean, but sometimes it's an ovarian or perimetrial abscess, so you have to use the ultrasound or CT scan if you happen to have one of those. That's something relatively new at Tenwick, and quite a blessing in that respect in our diagnostic abilities. Hemorrhage, again, something you deal with here as well, is a major cause of death in the developed countries, particularly in the less developed areas. If you don't have blood banking, you've got big problems. And even spontaneous abortion, criminal abortion, patients can lose a lot of blood before they've ever gotten in for care. We talk about antepartum hemorrhages, or APHs, abruption of placenta, and we'll just mention that. The placenta previa, you think always of the painless bleeding. Unless they're actually in labor, generally that bleeding is painless, second and third trimester primarily. And if that's the situation, it's placenta previa until proven otherwise, so you don't want to do a digital exam until you've ruled that out. If you have ultrasound, well, then that's obviously going to be a big help to you. Speculum exam may show that there's another reason for the bleeding. If the mother is in a transverse lie, you'd be highly suspicious of a placenta previa. The first time they bleed is usually kind of a warning that unless they're in labor, that bleeding often stops and it's repeated. So that's the kind of patient you may have the opportunity to transport to an area where there is better medical care as far as the blood banking. If you are going to deliver the patient, well, it's a good idea to do a double setup examination where you have the capability of going right to a cesarean if you feel the placenta low, or if you find that it is just maybe some extra bleeding and that there is no previa, you can continue. The abruptio placenta is a painful antepartum hemorrhage, and that's likely an abruption. It's a clinical diagnosis. Ultrasound is not always going to help you on that one. Obviously, the uterus may be very tender and tense and painful. Patient may be in shock. You would obviously sometimes have either a dead baby already, and that's a little less likely with the placenta previa, for example, where the baby dies ahead of time. And then there may have been a history of trauma or high blood pressure. So in that patient, you go ahead and examine the patient, you rupture their membranes, you get them transfused, you get them delivered. That's a much different type of management. The PPH, postpartum hemorrhage, we see a lot of that. And uterinatony is often the major reason for that. Sometimes the uterus has been overdistended because of polyhydramnios or multiple pregnancy. It may be a very prolonged labor, or it could be a very rapid labor where the contractions are not that well established before the delivery occurred. The lacerations of the birth canal. It can be a uterine rupture as well, so you have to think of that particularly if they've had a previous scar in the uterus. And they may have retained placenta that you need to remove. There's one situation that you're warned against in the third world medicine, is if you have a retained placenta and the patient is not bleeding when they come in, they deliver the baby, the placenta is still in, you might gently examine them, but don't try to remove that. That will often be a placenta accreta, and you're going to have a fatal exsanguination on your hands if you try to remove it. So that is one where you want to be very sure that you're dealing with just a detached, retained placenta that you can easily remove rather than pulling it apart in pieces. That patient may be well managed either with long-term observation or perhaps better, a hysterectomy. Uterine inversion, occasionally you'll see it. You want to replace it immediately. That was something we saw not too long ago at Tenwek. Was a chronic uterine inversion where the uterus had been inverted at delivery and remained that way months afterwards. That was an unusual thing and an unusual surgery. The obstructed labor is often what we observe. The patient has been sent in with sometimes trained personnel who have attended and followed closely and know that this is the situation, or maybe an untrained people where they're just finally giving up on the home delivery and getting them in. And that is either a result sometimes of CPD, but malpresentation can be the issue. And in our situation, where we so commonly have hydrocephaly and anencephaly and spinal bifida conditions, are just a real common problem around there. You might see a hanging breech come in where you've got the baby's body out and the head is still in the uterus. And I've handled that situation with a transabdominal tapping off of that hydrocephalus with just a large 18-gauge spinal needle right through the middle and through the skull bones. That will decompress that head to the point it will deliver vaginally and not have to do a lot of the destruction delivery techniques, which are also possible, and somehow cannulating the spinal column and getting the scissors in there and decompressing the head that way. I found it much easier to just abdominally tap that off. Sometimes it is subnormal labor that will respond to oxytocin, but often it is just maternal exhaustion and dehydration, and just giving that mom a liter of fluid will often kind of reestablish her labor, and sometimes you'll see these moms just go right ahead and deliver without any further interference with us or assessment or treatment. A PPH, obviously you want to see if you can figure out what's going on. Uterine atony is the most commonly seen. You can use Pitocin in an IV drip. You can give it intramuscularly. We often have ergometrine, which is good for lower uterine segment contraction, whereas the Pitocin often works on the fundus of the uterus. So if you have a situation where they've had a low-lying placenta, sometimes that ergometrine, which you don't give in hypertensive patients, that is a good drug for that, and often commonly used just routinely after delivery. Cytotec is really a good drug, and if you find that that isn't available where you're going, take some with you. They're usually 200 micrograms, or sometimes you'll be getting 100 microgram tablets, and you can give them per rectum, you can give them orally, you can give them vaginally. But if they're bleeding, we usually give them per rectum, and that will usually get the uterus contracted down. We also often use that at maybe a quarter of a tablet, 25 micrograms for cervical ripening, as long as it isn't the previous scar situation. So it's commonly used and very useful drug in the third world. And obviously fluid replacement and blood replacement. Anemia, we see a lot of, particularly in Kenya, where we've had a lot of malaria traditionally in that area. It's not unusual to see less than 7 gram hemoglobin coming in. Those mothers are more likely to die if they have a heavy bleed, postpartum bleed, or if they have heart failure around the time of delivery, just high output. And it's also obviously a risk for the baby as well. They often have had anemia for a long time. They have pregnancies repeatedly, often too close together, so they have low iron stores. They may have B12 levels that are low. They may have folate levels, so obviously vitamins may be helpful. We see advanced HIV as a reason for that. We see hookworms and other worms. We see tapeworms. We see roundworms. We see lots of different kinds of parasites that often just come out at the time of delivery on those. And then also malaria is probably the bigger reason for anemia for patients who have this chronically. And we're going to talk about malaria a little bit more at the end of this particular section. We usually transfuse the people if their hemoglobin is 5 grams or less, and particularly then also if they're symptomatic. We'll try to get them up between 8 and 10, and they're a little better likely to tolerate delivery. There are transfusion risks of malaria in endemic areas. Obviously HIV, syphilis, and in South America, Chagas is a problem with transfusion that's difficult to detect. Of course, hepatitis, so you load banking people need to be very thorough in their assessment of all blood that's donated there. And obviously you want to try to treat the parasitic diseases. Early pregnancy bleeding, different category now to the other end of the pregnancy. All women of childbearing age are pregnant until proven otherwise, and that's usually what's happening in Kenya. People are either pregnant, or they're just nursing a baby, or they want to be pregnant and trying to get pregnant. So that's usually what they're having, since there's about an average of 7 children per mother in our area of low-resource subsistence farming. Then all pregnancies are ectopic until proven otherwise. So you want to know that the pregnancy made it to the uterus. And bleeding that occurs before pain is usually a miscarriage. If they've been bleeding several days, finally have pain. On the other hand, if they're bleeding after the pain has begun, consider an ectopic in your differential very strongly. As I say, delivery to get there will often allow anemia or infection to develop. You want to evacuate the uterus as soon as possible and use antibiotics. We use it on almost every first trimester miscarriage. Give some doxycycline and Flagyl oftentimes as well. Criminal abortions do occur, and so you have to be thinking of that, particularly in patients. The history is a schoolgirl in high school someplace separated from the family. You just have to really anticipate that that may well have been an illegal abortion that patient came in with. Then you want to give antibiotics first before evacuating the uterus, unless the patient's so unstable you just have to go ahead, and then watch for tetanus. Ectopic pregnancies are very common, obviously, in areas of tubal disease, which we have a lot of, and it's a significant cause of maternal mortality, and probably one we don't even recognize. Obviously, you have to think about the diagnosis before you make it, and it is sometimes what you would think of as being the classic presentation of a ruptured ectopic with acute lower abdominal pain and hypotension. That is the classic thing, and occasionally we see that patient. More likely, those patients die before they ever get to see us, I think. More likely what we see is a chronic ectopic that gives a little more unusual presentation, intermittent pain, tender on exam, pelvic mass that may be present there and sometimes quite large, maybe 8-10 centimeters in diameter, and then a fall in hemoglobin kind of slowly. The HCG titers are not generally available. You might have a HCG test for a slide test for pregnancy test, but it's not quantitative, so that's not going to be routinely available most places. They're very expensive and not immediately available to you, even if you can pay for it and get one. Cholecentesis is probably more often used for diagnosis in that situation, and obviously a laparotomy with a self-injectomy to control the bleeding. And that sometimes that big massive clot around the tube, you just scoop out and then you find your anatomy, but there's just this big fibrin deposit around the tube that clot that you just scoop out of there, and then you can find out where your ectopic is in there. Tetanus is more likely to occur with a criminal abortion or delivery in unclean surroundings. Sometimes we see it in the babies, and some of the mothers put cow dung on the umbilical cord stump, so we don't advise that. And we do immunize our patients with 2 doses of tetanus toxoid during prenatal care and train in clean delivery techniques. That's generally what you try to do. HIV, I'm not going to spend a lot of time on that. We have very high incidence in some areas. We're probably around 5 or 6% of our mothers that are that. That most common reason that will kill a mother is the pneumocystis carinii pneumonia. So those patients who are identified as being HIV positive generally are treated with Bactrim as a preventative measure. But also there's anemia, toxoplasmosis, other fungal infections, spinal meningitis, diarrhea issues, tuberculosis, all those things complicated. We're also thinking in terms of preventing the transmission to the newborn. And these categories we're going to go through here: drug therapy, breast bottle feeding, etc. We have many children under age 5 with HIV, and we had very high figures in the early studies in the big cities, less likely in the rural areas, but it's throughout the countries, throughout sub-Saharan Africa. If we do nothing in identification, 30% of the babies born to an HIV mom will become infected. 50% of that time is at delivery, 33% is in the breastfeeding period, and the other 17% sometimes late in the pregnancy before delivery. So obviously that's an area where we can intervene. And one thing they talk about in breastfeeding is don't mix bottle feeding and breastfeeding. That seems to accelerate the issue of transmission. The highly active antiretroviral therapy, HAART, triple drug therapy, is now more commonly used in area where good HIV care is available through the United States PEPFAR program. They do give nevirapine syrup to the babies. We delay the rupture of the membranes. We don't do cesarean sections anymore. 10 years ago we were doing that. Not doing that anymore. And the mothers often can't afford the formula, and it's also kind of a social thing in the village is, why aren't you nursing this baby, breastfeeding the baby? You know, that means they have HIV, generally speaking. Everybody knows that. So those are issues, and most commonly breastfeeding is done and the HAART is continued. And obviously universal precautions are the best prevention for that. Now we're hitting malaria in the last part of our topic here. Malaria is really bad in pregnancy, and falciparum is the one that's the problem. Drug resistance is an increasing problem, and HIV makes that worse as well. There's 2 areas we're looking at here: the stable transmission areas, which is where it's commonly there all the time, seasonal, and in that situation you have a lot of acquired immunity. You have asymptomatic infection. It's generally the prima gravidis and the secunda gravidis the greater risk in that until they have survived that and have greater immunity. There's placental sequestration issues will hit, and low birth weight, infant mortality. In the unstable areas, it's a little different situation. Nobody has immunity, or it's low in the area. There is clinical illness as opposed to asymptomatic. All pregnancies, whether multigravidas or primaries, are affected equally, and I might add missionaries to that are affected severely by that if they've not taken their drugs and never had an experience with that. Generally severe disease, and you need to really get after that quickly. Severe malaria generally is hypoglycemia, diarrhea, there are often renal failure, jaundice, ARDS, cerebral malaria. Sometimes we see of our patients in the ICU with the decerebrate posturing and comatose. That is very common when Tenwik was having a lot of malaria. In the last 6 years or so, we've seen very few malaria cases relative to what we used to see. But other areas you're going to see it, so have to keep it in mind. And even in Tenwik, we will occasionally have cases of it, and we have to remember that that's still out there. Usually patients have gone to areas where malaria is more common, and then they come back and they get sick. What's going on in malaria? You have infected red blood cells that are being destroyed. You have accelerated destructions of the ones that aren't infected, and then they get severe anemia with all the consequences of that. They get flat water fever with intravascular hemolysis, and they're not making new red blood cells as well. In your laboratory findings, you see severe anemia, you see low or maybe normal white blood cell count, you see mild thrombocytopenia, and low serum sodium as well. Patients have irregular high fever. It's not necessarily every 4 days or every 3 days. It's just irregular fever. They have chills. They have headaches. They're dizzy. Those are common symptoms. They have aches all over, total body pain. They have anorexia, nausea, vomiting, abdominal pain, diarrhea. This could go along with just about any disease that we might see coming in. And then the non-productive cough or trouble breathing. This falciparum malaria is the most dangerous one. Causes millions of disease deaths each year. It is increasingly resistant to available drugs. And chloroquine, which is the safest drug to use in pregnancy, is generally not useful in areas of falciparum malaria. So we have to think in terms of other drugs. Falciparum makes little ring-forming formations, and they block up little tiny capillary networks. So it's these target organs that are generally affected: the brain, kidneys, intestines, and placenta. And as I said before, the falciparum malaria in pregnancy, primary gravidas are the particular risk. They've lost some of their acquired immunity, and they're often asymptomatic, so you see them just becoming chronically anemic without much in the way of symptoms of headache or other things going on. And the pregnancy failure rates is pretty much across the board. You have first trimester spontaneous abortions, second trimesters, you have preterm birth, you have low birth weight infants that are born either growth restricted or they're born preterm, smaller than what you would expect, stillbirths at term, neonatal deaths in the nursery, and sometimes congenital malaria in the nursery. The nurses have picked up a baby with malaria that made it through delivery but still himself has malaria and needs to be treated. And they seem to have a little higher risk of eclampsia and obviously maternal deaths. This placental sequestration is an issue. It seems to, in these little small vascular networks in the placenta, they sequester this parasite, and it blocks the transfer of nutrients through the pregnancy, so you get the IUGR, but then also oxygen in labor as well. We get stillbirths in labor as well. And this is more common in the prima gravida and the secunda gravida patients. And they often die very quickly after getting in the hospital, so you've got to really think of the diagnosis early, get started with effective treatment as soon as possible. The current treatment, according to the WHO 2010, and that's something you can download a PDF file and learn all about malaria in pregnancy. The intravenous or artesunate or temocinin derivatives should be used in preference to quinine, or quinine as we say in Kenya, for the treatment of the severe falciparum malaria in adults. So that's the drug of choice now, if it's available. If it's not available, then you've got to use the quinine, and 600 milligrams 3 times a day for 7 days. You can't stop short of that, and sometimes you give a second drug sometime during that course to be sure you've eradicated it. You can give it IV, which is preferred, but you got to add dextrose to it because it causes the hypoglycemia, and that can be fatal to the mother or the fetus as well. So run the quinine and dextrose, particularly if the patient's been unable to eat or is vomiting. I think we're at the questions and the comments right on time here, Lance, so I'm not sure how this is going to take place, so I'll let you take over here.
Okay, well, Paul, that was an excellent presentation, and your timing is impeccable. Very good. So I'll just open it up to the folks out there. Does anybody have questions? I'll start off. I'm an internist, so I'm going to defer to our obstetrical friends out there. Any questions at all?
Paul, I heard you talk about at one point chloroquine with patients who didn't have falciparum malaria. But do you have any prophylaxis for endemic areas that you'd recommend? And you came through a lot right there at the end, so I may have missed it.
Okay, for prophylaxis in areas where chloroquine is effective, yes, that is an effective treatment, but you can't use the artemisinin derivatives in falciparum areas as prophylaxis. And so the prevention is generally bed nets and trying to reduce malaria or mosquito access to the patients, and freestanding water and things where they might be multiplying and things like that. We've used drugs that are effective, such as some of the sulfa drugs, in reducing severe anemia, but it's not really preventing placenta, or that is acute malaria. It's just intermittent treating of it has been used to reduce anemia, but not the acute falciparum disease, particularly in the primies and the secunda gravidas. And then for people, I didn't really prepare to talk about doctors going to the area, but it's Lariam and Malarone are by and large, and sometimes doxycycline drugs that you can use going to an area where malaria is there, but there's not really going to be used doxycycline during pregnancy as a preventative drug. That's one of the no-nos on the list.
Very good. Anybody else? Let's see. I'm reading a question from Kelly. She says, are the medications you mentioned for various treatments readily available at mission hospitals, Paul?
Well, the ones that I have been to, yes, they have been, but I think you need to inquire as to your specific place you're considering going, and that's what I'll have to do when I go to Mbingo here shortly, is to see what all do we have there. Do we have the malaria drugs there, and we're at 4,000 feet there instead of 6,700 feet where we are at Tenway. So it is a little more common in the area where I'm going to be headed, so I need to learn a little bit more locally with the people that are there. And that's where you're going to find most of your information is from the doctors who are working there ahead of time, I think, communicating with them. And the drugs for the bleeding after delivery. I'm blocking on the name of Cytotec. Cytotec, seeing if it's available. So it's such a useful drug, but you want to be sure you take some if they don't have it.
Good. Anyone else? Paul, I had a question as an internist. I'll tell you what makes me nervous is, this is switching subjects a little bit, but premature rupture of membranes.
Yes.
So I guess two questions. How does a lowly internist determine that there is indeed a premature rupture of membrane? And then in 30 seconds or less, how do I treat it?
Okay. Preterm premature rupture of membranes prior to 34 weeks, you want to do your examination, get either nitrazine test or cesium meconium or amniotic fluid with vernix or something, or just a dry slide that shows a fern pattern under the microscope that makes the diagnosis. An ultrasound that shows oligohydramniosis, also reasonable evidence that you do have preterm rupture of membranes. What you want to do is give a certain course, maybe it's not clear whether it's 7 or 10 days or 12 days. We generally use 10 days of ampicillin and the erythromycin drug for treatment. And a lot of those, instead of going into labor, do prolong then that pregnancy for a while. And then you will generally want to get them out at 34 weeks if that's where you're going to have a good survival rate in your unit. So go ahead and induce at that point. So those are kind of the things that we think about when we have preterm rupture. If they're at term, then you want to get them delivered, but within they're past 18 hours and not going to deliver very soon, then you want to start your ampicillin. Anything less than 36 weeks and anyone with prolonged rupture of membranes more than 18 hours, getting it started on an antibiotic, because there's going to be a very significant number of those baby's going to get an infection problem in the nursery. The other thing you think about is before 34 weeks is giving the dexamethasone, which we use celestone, betamethasone in the States. We use dexamethasone abroad and get 48 hours worth of that. That's 4 grams every 12 hours for 4 doses, something like that. 6 grams, I guess it is.
How long, Paul, I'm sorry, if you have a full-term situation, how long how long would you suggest, like how many hours with premature rupture would you recommend that you start antibiotics?
We've kind of used 18 hours, because within 24 hours, if you're at 18 and you're nowhere near delivery, you know you're going to be at 24 hours. That's when the increased risk of infection goes up, particularly for the group B strep. So that's why ampicillin generally is effective for that bug.
Okay. Okay. If you'll look in the chat box there, Laura Smelter has a question for you.
Oh, okay. Hi, Laura. I think you have a choice of ceftriaxone and metronidazole. When 5-6 years ago, ceftriaxone was really expensive, and we had to limit that. And I think Amgen Flagyl does that. So I think it's an either-or choice, and I think more commonly we're using ceftriaxone than we are using the Amgen Flagyl, but that's because the cost and availability has changed.
Great, thanks.